Hey everybody, this lecture is going to talk about communicable diseases and the immunizations that may prevent them, so let's jump right in. Now, the goal of nurses in terms of infection control, as you probably know, is to prevent the spread of infections. We do treat them as well, but prevention is easier, so think about how we do that. All right, let's time travel back to foundations. I'm sure you know where this is going. All right, here it is. Proper hand washing, right? The most important intervention that can minimize the spread of infectious disease. During the pandemic, we learned a lot about our fellow humans and how effectively people utilize cough etiquette, which is also another important prevention measure. In the hospital, we have PPE that protects both us and our other patients. It's not uncommon to have a patient with an infectious respiratory disease and a patient without. So utilizing the proper isolation precautions can decrease the spread of nosocomial infections. All right, let's dive right in to some of the most common pediatric communicable diseases. Chickenpox, also known as varicella. Okay, your signs and symptoms of chickenpox include an itchy vesicular rash that starts on the chest, the back, and the face. These patients will have fever, muscle aches, loss of appetite, and sore throat. The primary infection from this virus results in chickenpox, okay? But after a person recovers from chickenpox, the virus remains in the body in a latent form that localizes in your sensory nerves, and it can reactivate later to cause herpes zoster, or otherwise known as shingles, okay? It is highly contagious. It's transmitted through, not shingles, but chickenpox. Highly contagious. It is airborne, okay, as well as direct contact. So it begins in the respiratory tract, and then after about a week, it will enter your bloodstream. It is now a vaccine preventable disease. I actually had chickenpox. I did not receive the vaccine. I think timing-wise, I was a few years behind, but it is a 2-dose series that we give for varicella. The diagnosis is usually according to manifestations, okay? You can confirm it in a lab, but usually when providers see it, they know what it is. Parents should be educated on symptomatic relief of fever and itching. So you can give Tylenol to reduce fever. We don't give aspirin for any childhood diseases. This is something that will come up several times, I'm sure, in this course, but aspirin is a big no-no because of the risk of aspirin-related Bray syndrome. And then we would always encourage hydration. The itchiness or pruritus, which is a hallmark manifestation of chickenpox, is managed through the calamine lotion and the oatmeal baths. Antihistamines could be given and help promote better sleep, but ideally we want to prevent scratching, because if we scratch, we are at risk now of a secondary infection, which can make things quite a bit worse. Nurses that are pregnant should not take care of a patient with chickenpox, okay? And children should be on airborne and contact precautions until the lesions are dry and crusted over. That is sort of our hallmark, you are no longer contagious chickenpox education. Measles is another highly contagious airborne virus, which has been in the news more recently because cases are rising again. This is also vaccine preventable. It is part of your MMR series. Incubation is about 10 to 14 days, and these little guys can remain in the air for about 2 hours. They're very durable. Your initial phase, you will have respiratory, right? Cough, runny nose, fever, some conjunctivitis, pink eye. Then they have the Koplik spots. So this is sort of your cardinal measles thing, right? Koplik spots in the mouth, followed by a maculopapular rash that starts at the head and moves down the body. Because of the induced immunosuppression and like immune amnesia of measles, it poses a significant morbidity and mortality risk globally. It really impacts regions like Africa and Southeast Asia. Treatment for measles is supportive. We're mainly treating the fever and the discomfort. Vitamin A can be used to decrease the severity of infection. They give it for about 2 days. So again, this is preventable via the MMR vaccine. It is a nationally notifiable disease. According to the CDC, there have been 16 outbreaks last year, which is defined by 3 or more related cases, compared to 4 in 2023. Most of the cases are in unvaccinated individuals that are about 16 months to 19 years of age. I will say that measles was considered eradicated in the early 2000s, but unfortunately cases have been increasing due to vaccine hesitancy since then. Okay, moving on, 5th disease, okay, or erythema infectiosum, not a Harry Potter spell, is a common viral infection in children that is caused by the parvovirus, okay? It is very important to note that parvovirus is dangerous to those in their second trimester of pregnancy. So you might have learned about this in OB, as well as those who have sickle cell anemia, because it can exacerbate anemia by stopping production of red blood cells in the bone marrow, and can also then create anemia in a fetus or then bring on an aplastic crisis in those sickle cell patients. It is very common in school-aged children during respiratory season. It's transmitted by droplet and contact, just like most respiratory infections. Fifth disease usually starts with flu-like symptoms: fever, malaise, headache, muscle pain, some GI issues like nausea, vomiting, diarrhea. It is characterized by this distinctive facial rash that resembles a slapped cheek. That usually shows up after the initial symptoms, which is ironically when they're no longer contagious. So following that rash, they will get a non-itchy maculopapular rash with like a lacy appearance on the body and limbs. And as with varicella and measles, we often just diagnose this symptomatically, but we could test for it as well. Comfort measures would be symptom relief, just like most viral infections. Okay, manage fever, alleviating any discomfort, rest and hydration are key. And then just parents should be told that rash itself is not contagious. And so once they see that rash, that child is no longer infectious. Mononucleosis is another common pediatric viral infection caused by the Epstein-Barr virus, or EBV. This has a super long incubation period of about 3 to 6 weeks. We don't really know how long the virus sheds, but we've seen high levels of this virus for up to 6 months after the beginning of an illness. It is affectionately, pun intended, referred to as the kissing disease because it's spread through infected saliva. And so we know how adults and adolescents manage to share that, right? Symptoms are fatigue, fever, sore throat, some enlarged lymph nodes, and also splenomegaly, so their spleens can be enlarged. So you could have rare complications of splenic rupture here, especially if they try to be active during the active disease, some airway obstruction, or Guillain-Barré, which is a type of peripheral nervous disorder. You may have heard about it in relation to flu vaccines. It can cause weakness and paralysis. Let's see, mono, diagnosed with the monospot test. Okay, we will check for antibodies. We will also see signs of infection like increased white blood cell counts, liver enzyme elevations. We would perform comfort care for these kiddos. Basically, it will resolve on its own, but it takes a while and these kids are tired. Rest is crucial for recovery, so we really need to encourage parents to let them get plenty of sleep, limit physical exertion, and avoid contact sports, again, because of that risk of their spleen rupturing. Roseola, another viral infection. This they sometimes called sixth disease. Okay, so if you noticed, we have fifth disease, we have sixth disease, and that's just because they're named very creatively by the order in which we often see them in children. So this is caused by the human herpes virus. 90% of cases occur in kids that are younger than 2. Both of my girls got it around 18 months of age, pretty much right on time. Very common in spring and fall, very common in daycare. Young children usually will have like non-specific irritability with other mild manifestations. So this can be really contagious before a diagnosis is made because, again, that rash will appear and then they are not contagious. Proper hand washing is really important to prevent spreading. As the fever subsides, which can be very high, I mean, that's how I knew. Both of my girls were like 103 and feeling fine, especially my second one. She had this 103 fever, but was just happy. And I was like, I bet this is roseola. I guarantee. And then, like, sure enough, like 2.5 days later, like rash came out. And I was like, that's it. So that will be your non-acute phase of the illness. It's these like little small rose pink maculopapular rashes that starts on the trunk and it can spread to the neck and face and extremities. Again, supportive treatment, hydration and rest, hydration and rest, hydration and rest. One important thing about roseola that you'd want to remember is that this is a time that you want to monitor for febrile seizures. We'll talk about those a little bit more in neuro, but febrile seizures are caused by fevers that come on fast and hot. Okay, and that primary age group are those toddlers. And so this is that perfect time where it's just a happy combination of a really high fever that comes really quickly and that age group that they might have febrile seizures. Okay, so parents should be advised to call emergency services for medical assistance, but it is also important to reassure them that febrile seizures are not dangerous, but they're scary, right? So they should be aware that that is a possibility with roseola. Hand, foot, and mouth disease. This occurs in schools and childcare settings in kids under 5. Okay, we really are in like the daycare diseases right now. It's caused by an enterovirus or Coxsackie virus, and it is spread through respiratory secretions, but also stool in this case. Hand, foot, and mouth is characterized by the appearance of these shallow, painful, ulcerative sores in the mouth with these red borders and a white or gray-yellow base. It has a non-itchy rash that can be maculopapular or vesicular, and it usually is on the hands and the feet. It presents as little red spots or blisters. So basically, clinical presentation lets us know what you can do, like a biopsy or a scraping, just to kind of figure out if maybe if you're worried like the differential is varicella or herpes simplex, we want to maybe sometimes make sure, but usually it's pretty easy to tell. So again, supportive treatment. I hope you all just said that with me and rolled your eyes. It's getting easy, right? So we're just going to support them. Cold foods and liquids if their mouth hurts. I know some adults that got this from their kids, and it's actually really painful as an adult. So it's just another one of those childhood diseases where the kids get it and they seem fine. And then as an adult, you get it and you're just like completely knocked on your butt. We're going to mention 3 parasitic infections really quickly because these show up on ATI exams and on NCLEX. The rest are in your book and you can supplement as needed. So scabies is the first. Okay, these are mites that take getting under your skin literally. They cause intense itching. They leave burrow tracks on the skin. Your close contacts with any patient should be examined and treated. Usually we use topical permethrin for this. The biggest concern with scabies is similar to with chickenpox, which is your secondary bacterial infections from the scratching. Okay, it's really important that they not break these open because now you have access for other things to get in. Next up, number 2, lice. You may have had this. You may have known someone who had this. You may have had it and not even known, okay? Lice is characterized by itching on the portion of the body where the infestation is. Usually this is often the head. Now, exams will sometimes call this pediculosis, okay? Don't get confused by the ped. It sounds like feet. Pediculosis is lice. Sometimes they don't define it for you, so be aware. Current transmission preference is close contact of heads. Okay, so think about taking selfies and like leaning towards your friend and you get your heads close to each other and the lice, they don't jump. They transfer via like hats and hairbrushes or that direct head-to-head contact where they can kind of just slither over. Okay, they're not leaping across rooms, but that is how you get it. Oh, real quickly, actually, before I move on, I know I just skipped forward, but about lice, I do want to mention that it is no longer an exclusion criteria for school. We used to say that they couldn't come back until there were no more nits, which are the eggs, but because lice don't really have any long-term health problems unless it's like a major infestation, but then we have other issues there that we're concerned about. A mild lice infestation isn't an issue, and so these kids can stay in school, okay? So you don't get sent home for that anymore. All right, finally, pinworms. These are the last ones we're going to discuss. They cause intense itching in the rectal area, especially at night. We diagnose them with the glamorous tape test, which is exactly what it sounds like. We place tape over the perianal area and we lift it off, and then we put it under a microscope to look for eggs. We have anti-helminthic medications for treating it, and usually all close contacts will be treated as well. All right, on to vaccines. We are almost done. As you are likely aware, vaccines introduce a weakened, killed, or a piece of a pathogen to trigger the immune system to create antibodies and memory cells without causing the disease. If you remember, there are 2 types of immunity, right? We have active immunity and passive. So active is when your own body produces the antibodies after an infection, and this is or immunization, and this is long lasting. Passive is when you are given the antibodies from another source, like a mother to baby via the placenta. This is temporary, okay? So this is why we administer the DTaP vaccine during pregnancy, because some of the pertussis immunity that we give through the vaccine will pass to the fetus, and then it will help until they can get it as an infant, all right? So the ultimate goal of vaccines is herd immunity. That's where so many people are vaccinated that the infections have nowhere else to go. They're jumping around from person to person, but everybody's vaccinated and they just fizzle out. We've done this with smallpox. If we look again at current affairs, we almost eradicated measles in 2000. I think I might have mentioned that. It's in my notes now. So a huge part of PEDS, especially in outpatient, is dispelling misinformation about vaccines. A lot of damage has been done in regards to vaccine safety and understanding. And so we really need to empathize with and educate families about vaccine hesitancy and also help to improve access to those populations that might have difficulty obtaining vaccines. So our role in vaccination, well, where we can have severe reactions to a vaccine, right, or a component. And so that's really the only standard contraindication that can be applied to all vaccines. So prior to administering a vaccine, we should determine allergy status of the patient. We should ask about a history of any adverse reactions to previous doses. It is important to educate that mild illness is not a contraindication, but if a child has a fever, we should probably wait, just because we might not have as effective as an immune response. We might not have as effective of an immune response if we vaccinate during a more severe illness. That was hard to say. You can tell I've been talking for a while. We should address fears with evidence-based information, not judgment. And then we also have to make immunizations as painless as possible, focusing on that atraumatic care. So we can use sucrose solution for babies, numbing creams for older kids, and distraction for all. All right. Now let's put this into action based on the clinical judgment model. A child presents with rash, fever, and a history of being unvaccinated. Those are your cues. So you analyze this and hypothesize that it could be what? Look at that poor little guy. All right, so thinking about we know from the lecture, and yes, this is an obvious one, but we're introducing this clinical judgment model here, right? This child likely has measles. That is our hypothesis. So now we want to start thinking about what we're most concerned about in this moment. And that can vary depending on their presentation. If they're stable, we might want to prioritize isolating them. But if they're not, we might want to prioritize airway or neuro interventions. So once we have determined our order of priority, this is where we would stop and think about what we know about measles in order to take action. Okay, so what are we going to do? What isolation precautions are required? Airborne, right? So there we are. Can we treat it with medications? Not really. So we're going to be looking at supportive care. This would also be a time to maybe consider education. However, we'd want to save that for closer to discharge, because the immediate well-being of the child is the priority, but it definitely is important to discuss it prior to discharge. So now we're going to take action. This is where you do your interventions, arguably the most important part of nursing. We're going to place that child in the appropriate room that we thought about in the last step with the appropriate airborne isolation. We want to educate the family on infection transmission, plan of care, and then we would administer any IV fluids or medications for supportive care and comfort. Now, I know I said implementation was the most important part of nursing, but it might be evaluation, because this is where we reassess and we ask ourselves, did it work? Is this child improving? Are they more hydrated? Are their symptoms better? Because if not, we're going to circle right back around to the beginning of this process and we're going to go again. Every time you enter a room in the hospital, you start this over. You assess, you take that information, and you determine what, if anything, should be done. And then you do it, and then you make sure it had the intended result. Rinse and repeat. And one day, not so far in the future, you will do this all without thinking about it in steps, okay? But for now, as students, we have this. You see it all over in ATI, and while it seems like it's tossed into the modules as like a piece to skim over, it honestly helps a lot if you slow down and you break down these case studies that follow the clinical judgment model to see how all the pieces fit together. We will be revisiting this framework a lot over the semester. And finally, a fun chart. So as I mentioned, the timing of vaccines are determined by a couple factors: the age, when the body's immune system will provide optimal protection from the vaccine, and then the need to provide protection at the earliest possible time based on the highest age of risk. So this is the 2025 chart. It's important to review it. You should know how to read it. You don't need to memorize it because it does change sometimes, and it might change now because we have a whole new committee. If you guys follow the news, the committee that normally sets all of these schedules out and makes these recommendations has just been completely overhauled. So we aren't sure from my pediatric standpoint what that's going to do to the schedule for the following year. If anything, it's a conversation for another day about how that might trickle down and affect access, but you don't have to memorize it. Just be able to read it, understand how to sort of make sense of it, because it is a resource that we have and you should know how to use it. Some exam questions will ask about some of the more obvious or critical vaccines. So you might want to be familiar with the meningococcal for teens, or maybe knowing which ones are live or which ones we give at birth. Those sort of categories tend to be asked about because they're a little bit easier to know, but you're not going to be asked, it's your child's 5th birthday, which vaccines are you going to get? That's a little less common to come up. But there is some familiarity you should have moving forward. There's some mnemonics for vaccines on websites like Picmonic or other sites if you're interested and you want to look into that a little bit more. I should have it linked, I think, on the Blackboard module as well if you want to take a look at just a short version of it. Okay? Whew. This concludes the communicable disease lecture. All right, I will see you guys in the next one.